All right, thank you. I guess there are brave people who are still here for my lecture. I want to thank the committee for inviting me. It's my privilege and honor to present psychiatry questions and lecture. Today's topic has two parts. One is on personality disorders, and other is about effect of isolation after the COVID and how we are handling that. So in the interest of time, I will do my best to catch both of these topics, but if I go a few minutes above, please bear with me. So first thing is about personality disorders, and I have no association with pharmaceutical companies, so that's my thing. So personality disorder, as you can read, this is the DSM-5 definition of personality disorder. But the question before we go to personality disorders is, what is a personality? Because disorder comes later. So personality is, as you define your family members, friends, maybe yourself. Disorder is when it starts affecting people around you or around your patient's personality. So disorder can be of different types, as we will see. But first of all, remember that main thing is people with personality disorder affect cognition, affectively, interpersonal functioning, and impulse control. So keeping that in mind, we have to understand what are the different areas which are affected because of the personality disorder, and then we will go individually into the clusters and individual personalities. It is an inflexible, pervasive, across broad range of personal and social situations. People with personality disorder unfortunately suffer not only themselves, but people who are around them. And this affects their occupation, this can affect their functioning with the families, and this is a long-lasting thing. Sometimes it starts way early in adolescence and carries on in the life duration. This is a pattern in which it is not explained by other psychiatric disorders. That means if somebody has bipolar disorder or someone is suffering from major depressive disorder. So those are different problems. Personality disorder should not be diagnosed in that situation. And as we'll see, that personality disorders affect in many ways, unfortunately, how we treat those patients in the medical field in general. And also, personality disorders are not related to any alcohol, drug, or other substance of abuse that has to be taken out. So what are the different reasons for personality disorders? One is most common, genetic factors. What does that mean? That means that patient is born in a family in which certain behaviors are normal. So they are already prone to that, or they have a family history or other factors which are affecting them. Also, some chemicals, neurochemicals, neurotransmitters affect them. And as we will see, there are certain personality disorders in which most of these play a role. Also, there are therapists in this meeting. Maybe you can attest to that. According to Sigmund Freud, if you look at his theories of development, some people are stuck in the phases of different parts of development. If you know about Sigmund Freud's theory of development, it is some fixation, either anal stage, oral stage, phallic stage, latent stage, or genital stage. So there are certain characteristics in certain personalities which do point towards that kind of Freudian stages of development theory. And also, people with personality disorders, they use different defense mechanisms. They apply different defense mechanisms and they learn over a period of time, and they affect their functioning. Very commonly used ones are fantasy, dissociations, isolation, rejection, splitting, passive aggressiveness, acting out. Also, very commonly we see people with, as we'll talk about, borderline personality disorder. Sometimes they use chaos as a problem, or they use things which you will see they're part of the defense mechanism they use. So what are the different types of personality disorders? So in order to understand it easily, we divided in psychiatry personality disorders into 3 clusters. They are called cluster A, cluster B, cluster C. Cluster A includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B includes antisocial personality disorders, borderline, histrionic, narcissistic. And cluster C includes avoidant, dependent, and obsessive-compulsive personality disorder. Also, there are some other personality disorders which are not DSM-5 diagnosed, or DSM-5 did not put them in there, but they do consider in other areas. So sadistic personality disorder, for example, and it still appear in literature, as you can see, and we'll talk about it also. So cluster A personality disorder, as I said, include paranoid, schizoid, and schizotypal. So these personality disorders have a lot of things in common, but in paranoid personality disorder, mostly the patient suffer from paranoia. They're always questioning. They're always not sure about your motives. For example, and please, one thing I want to say, once you read about personality disorders, once I finish my talk, please don't start diagnosing each other or your family members. This is in general terms. So personality disorders are not that we start blaming anyone. There are people who definitely are worried. They ask questions. For example, as a psychiatrist, when I see patients in my office, many times they ask me, where are you from? Where did you go medical school? Where are you practicing? If you say, no, it's none of your business, then let's talk about your depression or anxiety, actually we are augmenting their paranoia. So when somebody asks questions like that, it's okay to give them brief information. It's okay to talk about whatever they want to know. But there's always a limit setting where you cannot cross that. So these people who are suffering from paranoid personality disorder, these people sometimes are very easily irritable. They become hostile. They are the ones sometimes who are always looking for this not justice being done. They are always standing up and saying, oh, I'm being discriminated, or things like that. So they are paranoid about these things. And sometimes they are the ones who will actually go file cases against doctors or therapists and providers also, in general terms. So be careful when you're dealing with these patients. Document very clearly how you are talking to them, what are you addressing, so there shouldn't be any problem. Now, another type of cluster A is schizoid personality disorder. These are the people who likes loneliness. They're isolative. They don't have interaction with other people. They try to work in total isolation. One example, as some of you might remember, the Unibomber, who was in Atlanta Olympics, he did horrible things. When his whole life story was investigated, he was living in a cabin high up in the mountains in isolated area, but he had his own ideas that how to take revenge, what to do, how to create chaos, and all those things. So these people don't have friends, they work in isolation, and they don't have any relationships. On the other hand, schizotypal personality disorder, which is the third type, when some of you, I have medical students over here and residents, just to keep in mind, this can be one of the board questions also, that what is the difference between schizoid and schizotypal? So remember, schizotypal have odd thinking, they have a magical thinking, they have a more like schizophrenic kind of flavor to their thinking, but the major difference is they do get into relationships, they do get married, they do have children. So schizotypal and schizoid, although they do sound similar, there are a lot of common things, but the main difference is schizotypal can be in relationship. So this is one of the questions they ask in boards. Now, coming to cluster B, which is bread and butter for many therapists and psychiatrists. Cluster B is, as we saw earlier, includes antisocial personality disorder, borderline personality disorder, narcissistic and histrionic. So this cluster is very interesting because in psychiatry or in our patients, we don't see anything specific, just one personality disorder. Most of the time you will see the disorder is in cluster form. They might have some narcissism, some antisocial behavior, some borderline behavior, or some histrionic behavior. So what is antisocial personality disorder? This is a disorder, in general terms, a lot of people think that people suffering from this disorder might be the ones who are the most criminal or in jail. And not really. They do have criminal behaviors, but most of the people in jail do not suffer from antisocial personality disorder. Antisocial personality disorder is very interesting in many situations or many cases. These people might be actually at a higher post. They might be very successful because they don't care about norms. They create their own norms. For them, the norms are for the weak people. They don't care about red signal versus green signal because who cares stopping at red? So they have antisocial behavior. They don't like to be told what to do and what not to do. And that's where the problem comes, as we will see how you treat them. So these patients do suffer from a lot of grandiosity also. And as we're talking about borderline personality disorder, most of you might have heard this term in many medical cases or your psychiatry patients, and therapists do work on this a lot. So borderline personality disorder is now the future investigation in all studies and trying to figure out how to treat them. So borderline personality disorder, why it is called borderline personality disorder? The borderline personality disorder means it is at the border of neurosis and psychosis. So these patients do things which are not commonly done by other people. So they are very needy sometimes. They have a very unstable affect. Their mood and behavior is unstable. And there are many names given to this disorder over the years. As you can see, ambulatory schizophrenia, as if personality, pseudoneurotic schizophrenia, psychotic character disorder. And most important thing is, when you're working with these patients, you have to diagnose and then understand what they're doing. The pathology or the psychopathology, you can say, is that these are the people, when you look at their growing history, while growing up, parents, let's say a mother figure, not necessarily a female, but even father figure who was not present, these people get attention only when they create something chaos. Otherwise, they are not getting the attention. For example, mother is busy, maybe on telephone or on computer or something, and the little child is trying to get attention. They keep on yelling, "Mom, mom, mom." Mom is not responding. The only way mom will respond when they take a glass, smash in the wall. So now there's a chaos. Then mom comes running. What happened? What did you do? So they learn over the years, unless they create a chaos, nobody will pay attention. And they feel abandonment. They always feel they're going to be abandoned. So they create chaos, so they keep attention. So if you work with a therapist, and therapists can tell you that when they're dealing with these patients, it's a very interesting thing how you have to go back in the childhood and see how they were raised, what were the problems. So borderline personality disorder is very important in many areas in psychiatry especially, because when we see these patients, we have to give them a lot of attention in order to understand what's going on and get them stable and better. Now comes histrionic. This is also part of the cluster B. Histrionic personality disorder, as maybe you can surmise from the name, these patients do have they are very emotional, easily excitable. They are always flamboyant kind of behavior. They're always excited to see you, but they lack a lot of empathy. They lack relationship. They are not, it's very superficial, whatever they're doing. And it is very common with people who are otherwise cannot get attention. So they create something and they get attention. So some of these patients, if you read about it, they are very good dramatic people. They might do very well in movies industry or drama industry. So they do learn how to behave, but not necessarily they have understanding of this illness, and that's why sometimes they don't even complete those things. And then comes narcissistic personality disorder. One thing I want to say over here is, sometimes, unfortunately, these disorders are projected on the patient by the family member, somebody as a derogatory or negative way of saying that, oh, you are narcissistic, you are this. But in reality, narcissistic personality disorder is very important to understand, because these are the people, they feel that they are entitled. They can do anything. Nobody should question them. Nobody should ask them. They have a grandiose feelings. But the reality is, deep inside, they are very fragile. They are very weak. And if you confront them, that becomes their ego problem. And that's where the narcissistic injury comes in. And they become hostile. They can become angry. And if you look at now all this cluster B, you will see a lot of things in common. So there are people, if you look around in our society, some of these narcissistic patients or people have been successful in many other ways. They can be political leaders, they can be successful businessmen, they can be all. But whenever you see them, be careful. If you confront them, if you cross their path in a wrong way, then you will see that, like they say, true color, what comes out. So, coming to cluster C. Cluster C is, as we saw earlier, consistent of obsessive compulsive disorder, personality disorder, and avoidant and dependent. So remember, obsessive compulsive personality disorder is different than OCD or obsessive compulsive disorder. Obsessive compulsive disorder is, like old terminology in DSM-5 used to be axis 1, but this is axis 2. So obsessive compulsive personality disorder, these people are very kind of engrossed into orderliness, like a drill sergeant. You have to be there at 5:05, and if you're late, then they will be angry at you. These people suffering from obsessive compulsive personality disorder, they are very rigid in many ways. They are very stubborn, indecisive, and they always want to do things in a perfectionist way. So remember also, there's obsessive compulsive personality is okay. When it becomes a disorder, then that's not okay. So I'm just using an example. Please don't take me in a negative way. Sometimes we go to, let's say, Costco, and I went with a friend. We were shopping. She wanted to go one aisle to the other in a systematic way. I have my list, I want to go here and there and over there, and she got mad at me that why you are not doing it in a systematic way. Then I start asking her question, and she was really mad at me because I'm not proper. So these people can become very angry in that sense. But it's okay to make a list. It's okay to do it properly. But when you get aggressive or angry or upset, then that's a disorder because it is now affecting other people. So if you go to shopping and you make a list, does not mean you're suffering from OCPD. You might be OCP, obsessive compulsive personality, but not necessarily a disorder. So that's why it is to keep in mind. Then comes avoidant personality disorder. And as the name sounds, these people, they are extremely sensitive to rejection. That's why they avoid everything. They will do whatever others want to do. They are not asocial. They are social people. They want to be there. They want to be participating in activities, but they do not say anything. They are just sitting in a corner because they're always afraid of something goes wrong. They are afraid that they might not. So that's where the inferiority complex comes in. So they might suffer from self-inferiority complex, and they need reassurance, and as we'll talk about in therapy in a minute. And also, dependent personality disorder. Dependent personality disorder, they are always subordinate to their own needs or other. They always prefer everybody else do first, and they will stand behind and let other do. And also, they lack self-confidence. They don't come forward and say, I want this or I want that. So they stay behind, and they don't want to be alone, but they end up being alone. Because if you look around, you might have some examples in your friends or family. They're always, where are you going? Can I go with you? So whether you're going east or west, they're always depending upon whether they wanted to go other direction, they'll just depend on you to take them other places. And so in this disorder, they are very passive, they are very dependent. So if you now, as we have seen all the three clusters, if you look at different personality disorders, you will see sometime people who got together, they might augment each other. And we'll talk about it in a minute, how one personality disorder, person suffering from one personality disorder, get together with another personality disorder, and they might make a good friends, good couple, good parents, or things like those. The other variants of personality disorders which are not in DSM-5, but they are in literature, one is called passive-aggressive personality, as the name says. They are considered psychiatric diagnosis, but is no longer classified. And persons with passive-aggressive personality are characterized by covert obstructionism. If you see, these people have a negative towards everything. They are very stubborn. They don't want to change. They don't want to, but they won't do anything either. So they will not come across and say, nope, this suggestion is wrong. They will say, well, if you want to do it, but I won't do it, and then start having arguments about that. So they are passive-aggressive. Their aggression comes out when you confront them. Also, in the same way, persons with depressive personality are characterized, let's see. Some personality disorders, which is not, again, in DSM-5, but it has been in literature, is sadomasochistic personality. So these are the people who enjoy inflicting pain. But remember, it's not that it is one of the sexual personality disorders, but they enjoy inflicting pain. And sadistic personality, for example, these are the people who are always very condescending. They are very angry. They create problems for others, especially with their children. They insult them in front of people, and they don't feel anything wrong about it. So sometimes this is also there, but for the sake of discussion and literature, I included in this. And these people are not motivated by desire to drive sexual arousal from their behavior. So that is a distinction. And so now, as we have talked about the personality disorders, and we know some background of this, how to treat them? So remember, one thing which is very important, medications are not the answer. So if somebody thinks that you can put someone on medicine and they'll be fine, unfortunately, that's not going to happen. The mainstay of personality disorder treatment is therapy. And there are different types of therapies, and as we will see. For example, paranoid personality disorder, in this case, therapists should be straightforward. Like I said before, if you don't answer their question straightforward, they will think that you're hiding something. They will think there is something missing. So use that technique, answer their questions, and then limit setting with them how far you can go. Also, obviously, if the things are not stable or well, we use antipsychotic medications, ideally very low dose, atypical antipsychotics. Don't use older antipsychotics because they have more side effects. And if there are other comorbid problems, then we use schizoid personality disorder. Similar thing, that in this whole cluster, the treatment is again therapy. Schizoid personality disorder, if you diagnose a patient with schizoid personality disorder, so remember, these people are quiet, isolative, lonely, they don't have any interaction. So sometime when you talk to them, they do come across as suffering from depression or they have anxiety. So sometime we do use antidepressant medicine, anti-anxiety medicines, along with maybe antipsychotic medication to help them understand the severity of the problem and the illness. And also, I would like to point out at this time is that giving medication to the personality disorder is okay if there are comorbid problems. See, the thing is, if you have like a football player who's $1 million player, every week we look at him and enjoy his game, but if he gets injured, so it doesn't mean he's no more a $1 million player. It simply means he needs his fracture to be treated. So similarly, sometimes there are emotional fractures. So they are okay to be treated with medicine. Medicines are like crutches or like nailing or like giving a plaster on the leg if they have broken the leg. And after a while, you don't need it. So if they're working in therapy, if there are therapists in this audience, maybe they can attest to it, that it is okay to have some medicine so they can work in therapy. So we use antidepressants, anti-anxiety as supplement medication, as giving them some support in order to work through their issues. Schizotypal personality disorder is very important in this treatment plan because with schizotypal personality disorders, we do treat them for their problems, whatever they're having, magical thinking, odd behaviors, odd thinking. But the main thing is do not confront their magical thinking or odd behaviors because then they won't come to you. These are the people who are sometimes involved in cults. They sit and wait for the mothership to come from, which is parked behind Jupiter. So one day it will land and they are ready with the passport and $5, if you remember, that happened in Texas a few years ago. So this cult can get together and they create this kind of magical planning that aliens are coming and we all will be living somewhere else. So do not confront, do not negatively say that, oh, this is never going to happen. Listen to them, let them express. Then they feel comfortable and then you can educate them how to move forward. Now, coming to cluster B treatment. Cluster B, antisocial personality disorder. If you have a patient who's antisocial, you diagnose them with antisocial personality disorder. It is not easy to confront them. It is not easy to talk to them. It is very hard to gain their trust because there is something behind their whole persona that needs to be addressed. And one of that is that they are very self-destructive behavior. They do not want sometime to be told anything. So they feel they're on the top of everything. So in order to treat them, you have to help them understanding that, yes, you are what you think you are, but let me help you with this, this, this. So it's very important to also keep in mind that who brings these patients to us. Antisocial personality disorder, unfortunately, will not decide one day, okay, I want to get better, let me go see a therapist, let me go see a psychiatrist, or even my primary care physician. It is the family, it is the friends, it is the job, or somebody will encourage them. So they will have a lot of mistrust when they come see psychiatrist or therapist. So we have to help them. They are always reluctant. They always push people away. That's how they work. And then they blame others. So we work with them, we talk to them, we try to understand them, and then we help them with medication, and a therapist will help them how to see. These are the people who do very well with individual therapy, or sometimes even in group therapy, because they feel otherwise scared in individual therapy because then they cannot say things. But in group therapy, they feel comfortable and they will say things, and they might say other things to the other patients. But good therapist will help them how not to be condescending and negative, and that's how they learn. Similarly, as we talked briefly about borderline personality disorder, the treatment is again the same way that it is therapy. Cognitive behavioral therapy is one, but dialectical behavioral therapy is very important, and it's a huge area of interest, and it is being used a lot. But DBT, you have to have a special training in DBT, number one. Number two, DBT, as it says, dialectical behavioral therapy, any therapist who's doing DBT need their own therapy sometime, because they need to talk to colleagues to debrief themselves, decompensate themselves, because it's a very intense therapy in which patient and the therapist are communicating all the time. Patient can pick up the phone at 3 a.m., call the therapist, hey, I can't sleep, I'm gonna go kill myself. So therapist has to say, no, wait, let's talk about what's going on. So they thrive on creating a chaos, and therapist has to be there to help them. And these patients, unfortunately, they try to harm themselves, or they threaten to harm themselves. So please, never ever confront them, never ever challenge them. All right, you want to cut yourself? Let's see what you do. They will do it just to prove you wrong. And that sometimes can go bad, and they can hurt themselves in a more serious way. So we work with them as hand and glove kind of thing in DBT, and always there. And similarly, after the therapy comes the medication. They do need medicines. There is one study in which they are showing atypical antipsychotic medications because they are also mood stabilizer. Olanzapine was studied, and it is still being used in some cases, but we can use any atypical antipsychotic, keeping in mind the side effect profile and other things, and we treat them. Also, antidepressants help them, and anxiolytic medicines help them. And also, one thing which is also very important at this point is these patients are suffering from other medical illnesses also. So whenever we give any medicine, we have to make sure it is not gonna interact with their other medicines. And also be careful, because these patients can overdose. They can threaten, I'm gonna go kill myself. So unfortunately, these people can actually attempt it. So if you give them a medicine for any medical reason, and if you know that they have a borderline personality disorder also, so try the medicine which, if they use it, will not be dangerous. And I'll just be very straightforward. I have a patient, she has IBS, and she has a borderline personality. So our GI doctor gave her lots of amitriptyline for the GI problem. She went home, fought with her husband, took tons of amitriptyline. Amitriptylines, as you know, tricyclic antidepressant, they're dangerous in overdose. All medicines are dangerous, but tricyclics are like giving somebody a gun and some bullets and see what you do. So it can cause cardiac problem, that can cause other issues. So this lady was lucky that she didn't take enough to kill herself, but she did take a bunch of them, and then she was in the ER and then end up at Lord's Counseling Center. So then I had to talk to the GI doctor and request them, please avoid this medicine. So borderline personality disorder, if you have a patient with a borderline personality disorder, you will see a lot of these behaviors, and that's where you have to be careful. And again, therapy, CBT, DBT works. Histrionic and narcissistic personality disorders, treatment again are therapeutic, the therapy helps, but medications can also help. But the key is, again, kind of catering to their grandiosity and their need, and a good therapist knows how to talk to them and help them. And these patients, for example, histrionic disorder, patients suffering from histrionic personality disorder, they do have good insight sometimes. So it's an insight-oriented therapy works very well for them, rather than supportive therapy and all that. And in the narcissistic personality disorder, we have to be careful again, because their ego is very fragile. And if you confront them, they will never come back to you. So you have to work with them. Insight-oriented therapy works, but over a period of time. Cluster C, personality disorders, avoidant, dependent, and OCD. In avoidant personality disorder, these are the people who are, as we saw earlier, suffering from inferiority complex. They need supportive therapy in the beginning. They will do better when you give them assurance. Their self-esteem has to be improved. And as they are suffering from rejection, sometimes they have depression. So antidepressants along with anxiolytic medicines can help them. And also with the dependent personality disorder, again, the similar therapy which include insight-oriented, they can do better with antidepressants also, because they are very dependent and they're always looking for some assurances. Once their mood is better, they work good in therapy. And obsessive compulsive personality disorder is, as you can see, is one of the interesting disorder in which the treatment is very good, because patients themselves see them doing things and they have a more insight towards their illness. They are the most common people who actually come and ask for help, that I cannot stop doing this. I cannot keep becoming anxious, and anxiolytics help. And sometimes we use low doses, benzodiazepine initially to help calm down their anxiety. And then, as you know, SSRIs are very good medicines to be used in anxiety disorders and depression. And OCD also gets better. Their ruminations, obsessions get better with SSRIs. So, coming to part of this talk, as we have talked a few things about other topic. The main thing which I would like to emphasize is, please, when you have a patient whom you're diagnosing with personality disorder, do not diagnose them with a personality disorder in your first interaction, because sometimes they are having other issues that might be totally wrong. And remember, as a psychiatrist, if some of you are interested in psychiatry or have seen, when you write a personality disorder in their record, it sticks with them like anything. So whenever this patient is in the ER doctor looks at, oh, borderline. So these patients get second grade treatment right away. It's not that every ER doctor does that, but sometimes ER doctors, when they look at it, oh, she's just always making probably these threats. That can be dangerous. I had a patient who went to ER. She was complaining of abdominal pain, and she had bipolar disorder as well as personality disorder. Unfortunately, the doctor, as ER is very busy, and psychiatry patients are always fifth in line. First is trauma, cardiac, other pulmonary patients take precedence, and psychiatry patients are sitting way back in a different room with somebody looking at them all the time. That lady was put in the room for several hours waiting for psychiatry consult. When psychiatrist came, that lady was already having fever, she was vomiting, but 5 hours had passed. She was suffering from Depakote causing pseudocyst, pancreatic pseudocyst, which they found out later. She wasted 5 hours. It could have been ruptured and could have been huge medical issue. So the point again is, when the doctor saw probably borderline personality, bipolar disorder, everything is non-functional, everything is taking backseat. So when you diagnose somebody with personality disorder, you have to have very compelling evidence, and you have written in your notes why you think somebody has personality disorder or whichever your diagnosis is. Most of the time when I see the patient, I always write, patient might have borderline traits. Patient might have. So down the road, after a few visits, if I still see that behavior, then I say, yes, it meets the criteria for disorder. Or sometimes I get patients from other doctors and I see their notes. They've been seeing them for 5 years, 10 years. And if they say the same thing and I see the same thing, yes, then we can diagnose them quickly with the personality disorder and then help them understanding how to treat it. And also, very quickly, the therapy, as I said, is the key. And CBT, DBT, insight-oriented, supportive therapies, all these therapies do help along with medications. So I just wanted to give reference for these personality disorders. These are the books I consulted and wrote. So the second topic is how much time I have. Okay, thank you. Second topic which was assigned to me to talk about is risk and complications of social isolation. So this topic came to forefront right now since for the last 2 years we are suffering from COVID and social isolation is an issue. So we have to differentiate between social isolation and physical isolation. As you all might have heard of, that in areas where somebody is punished, they put them in physical isolation for many years sometime. Some of the political leaders around the world had suffered from that. So physical isolation is different from social isolation. And as we will see, social isolation is typically refers to solitude that is unwanted and unhealthy. So what happened is, since COVID, we got a lot of problems and we were told to do things in a different way. So socially isolated patients may lack friends. They were used to going to job. They are unable to do things. And loneliness, working from home. This is an interesting point. Initially, when there were restrictions, people thought that working from home is fun. I will do great at home. But gradually they realized that those 8 hours or 6 hours or 10 hours which they were away from home is now suddenly become totally different. So they are working from home. Before you do go out and work and come back home, so there is a gap. Now you're sitting in the same 4 walls, going to the kitchen, coming back, sitting again, eating again. After a few days, it became a problem. And not only problem for the person who was working outside and coming home, it was for the person who was before at home, for example, wife, and now husband is 24/7 there. That created huge problem because suddenly he started noticing this is wrong, that is wrong. So she said, quiet, don't tell me what to do. And that's where a lot of confrontations happened. That's where a lot of problems happened. So that working from home became a problem. So that's why there are some literature now coming out in which they are doing studies in which working from home is creating a huge problem. And if that has led to working from home, for example, has led to many problems. I'll give you an example of San Francisco. In San Francisco, there were all these office buildings and all those workers who were working in those buildings, because of them, there were a lot of businesses thriving because of them. Now everybody is working from home. So what happened to those small businesses? They start losing money. There's no person. There was a time when the working from home started, and you can Google it and see, U-Haul had no trucks in San Francisco because everybody was moving one way towards Arizona, going back home, living in other states, and San Francisco lost a lot of their revenue and everything. So all these things created a total different type of problem. And COVID-19 related problems created many things. For example, no activities, isolation, separation from family and friends, and also effect of isolation on older people. If you have worked with nursing home patients and all that, and you talk to the families, they will tell you because of this isolation, nursing home patients were even suffering more. Before, children would visit, grandchildren would visit, but not anymore. So those patients suffering from social isolation, first they were having whatever reason they're in nursing home. Dementia is one reason, but there are many other reasons they cannot function with age and all that. So they were suffering a lot from this. And daily routines changed. So that led to different consequences of social isolation, mental and physical. So we, in psychiatry, we were doing face-to-face. I mean, I've been in practice for the last 24 years. I never had even imagined that I won't be seeing my patient. In psychiatry, we work with person. So what happened with COVID was we are making telepsych. We are talking to them on telephone or video calls. Now, patients, that interaction changed. So a lot of patients who used to come to us from nursing homes, from homes, they were suffering even more from depression and anxiety. And not only the people who had depression, but it created total new kind of depression, and they are totally new physical problems. And these are the consequences because there is no physical activity as such. So that led to depression, anxiety, fear. That was still a problem, but also we saw more sedentary life. So cardiac issues, GI issues, psychiatric issues, all these problems, respiratory issues became an issue with our practice. And also, because of COVID, or in general otherwise, because death is inevitable, so loved one died. They cannot even go there. These patients who were suffering in the hospital with the COVID, now the family cannot even sit next to them. So there was a huge problem for the people who otherwise they were fine, but now they cannot even visit their mother, father, brother, cousin, whoever was suffering. So the death led to worsening of depression and made it bereavement even more. And also, the worst thing is fear of unknown. What's going to happen? And somebody, I mean, I'm not saying in a negative way, but I was traveling during COVID time, and in aeroplane, somebody sneezed. That created a whole chaos about everyone. Before that, they used to say, bless you, hopefully you're fine. But now the person sneezed, everybody was moving away from that person. And that is fear of unknown. What's going to happen? So these kind of attitude or behavior totally changed our society. And it is creating more. Somebody coughs, and everybody looks at him. It's just a cough. I was having a dry throat. No, are you okay? Are you COVID negative? So this fear of unknown created many problems for people. And then the social isolation led to substance abuse problem, alcohol, marijuana, other drugs. So this is like keep on snowballing. So when I see these patients, so a lot of time they are suffering from psychiatric problem to start with, but now they are suffering from substance abuse also. Benzodiazepine became the drug of choice. I have patients who were getting benzodiazepines from their primary care physicians, and that was okay for the short period of time. But now, over 2 years, they are getting lots of benzos. Unfortunately, there are different types of benzodiazepine, which are short-acting, medium, long-range. The short-acting benzos are the favorite medicines for many patients, and they are highly addictive. So substance abuse led to now the prescription abuse. And then, as I briefly said, there's a history going on with domestic violence, a lot of problems between family members, child abuse. So all these are the consequences of social isolation. And if you look back and you see these patients suffering, now things are getting better. We have learned a lot, and hopefully we will be better prepared. But at the same time, we still have patients in nursing homes and other places who are still suffering. And so what to do about it? When somebody has this kind of problem, there are different ways of treating it. One is We have to educate our patients or ourselves also about self-care. Engage in relaxing activities, exercises, reading. Sometimes even if things are okay, you can go jogging or exercise like that. Follow healthy routines. Stay connected via phone calls, social media and all that. But please stay away from the negative information because people are ill-informed. These conspiracy theories that this is all created by someone to kill people, this and that. It's an illness. Yes, you have to treat the disease. But this ill-informed informations are a very big problem, and avoid the rumors and things like those. Engage in therapy. Therapist, one good thing about telepsychiatry or video psych is that therapists can now do therapy from home to the patients who are sitting, and before they used to go see them, but it is helping a lot. At least half an hour, 15, 20-minute sessions during the worst time. Some of the therapists took it on themselves, and they were doing multiple patients, short therapies, not necessarily whole hour, but that helped a lot. So therapy is very important. And learn your daily routines again. Do things again which are good. And also at the same time, educate your patients that it's okay to go and talk to your psychiatrist, go see a psychiatrist, go see your medical doctor, and take some medications for anxiety and mood and all these problems which can be helpful. And at the same time, stay physically active. Don't do things which makes you more sedentary, because these medicines sometimes have side effects which need you to be more active and mobile. And I will finish my talk in just giving you an example that I had a patient who came to me during this COVID time. We were still seeing some patients who couldn't use the cell phone and all that. And that lady, she told me, she said, Dr. Hashmi, can you please make an exception? I want to come see you because I've never used iPhone. I don't know how to do video call. So a lot of time, this whole education is very important. And luckily she has a very intelligent grandchild who sat with her and explained her how to use iPad, so where we can do video call. So my point is, educate your elderly patients, educate them, help them so they can not live in isolation and they can be also active. I think I'm done, so any questions? Thank you. Dr. Ryan.
On your atypicals that you're talking about using for borderline and such, are you talking about the ones like Caplyta, Latuda, Vraylar, or are you talking about other ones?
Sorry, I didn't get the whole thing.
Read it again?
Yes, please.
My question was, when you were talking about using atypical antipsychotics in the treatment of borderline personality disorder, were you talking, and you said newer generation, do you mean like the newest, like Caplyta, Vraylar, and Latuda, which I like because they don't put weight on them, or are you talking also about Abilify, Geodon, Seroquel, Zyprexa, so on?
All of these are good. The one which did a study is olanzapine, but in reality, I use all of them. I use Vraylar, Rexulti. These are all the brand names, which is, do use. But the only thing is how we see their cost effectiveness, because newer medicines are more expensive, and the generic one. And the study, like I said, is of olanzapine, and they did show improvement in behavior and mood issues, yes. All right, thank you. Thank you very much.